Now I invite Dr. Sony and Dr. Sunil, who are the other presenter, to come on the dais.
Thank you, sir. Really thank the chief instructors of this to have me here, one of whom has been my teacher, the other one my student. So, congratulations on becoming a first-year resident in ophthalmology. To all my residents who have come in. What next? So maybe ophthalmology was the first choice, and we expect you to have certain qualities there. The absolute pursuit of perfection, excellence, astute observers, liking one-on-one interaction with patients, action-oriented, and a lot of other qualities that will make you innately interested in ophthalmology. But then if ophthalmology was not your first choice, so maybe you finished your MBBS 1 to N years ago, and then you gave your entrance exams with MCQs in mind, reading all subjects, and had less exposure to ophthalmology as a UG. Then you land up in some kinds of dilemmas. And what are they? They're being part of a fast-paced OPD, learning documentation and wondering when you're going to handle patients actually and directly deal with them, and then wondering what about your duration of the learning curve. You have dilemmas in OT about the variety of operations you see, about the instruments that you do not recognize, about your hand-to-eye coordination in microscopes, and operating in a limited space, and about extreme precision required, as well as the steepness of your learning curve in acquiring surgical expertise. So the duty of us teachers here are to develop interest in the students with hand-holding at every step, being patient during their initial staggering steps, and finding extra time to train them every time a new batch comes in, and forgive their early mistakes and offer constructive criticism all the way. The most important thing here is communication for orientation of the students. So direct interaction with the new incumbents is a must. You have to ask about their background, the medical colleges, the teaching level, the confidence level in the subjects, the internship that they did in their medical colleges, and respect whatever level they are at, because it's our duty to bring them to our standards and the standards of being a good ophthalmologist. We should give them a list of what to do and spell out what not to do. And of course, a timeline of duties and responsibilities should be provided so that they know when they have to, up to what extent they have to dedicate themselves purely to documentation, when will actual surgical training, begin, and things like that. It's better to provide a structured curriculum where the importance of detailed history taking in examinations is emphasized. This is an emphasis on careful documentations of all findings, including diagrams both of the anterior and posterior segments, teaching how to use the diagnostic equipment, and special workshops on basic life support, on research methodology, on ophthalmic photography, and also attitude, ethics, and communication in ophthalmology. So we can sell ophthalmology to our residents by telling them that you are going to become a complete doctor. You're going to have medical, surgical, procedural, as well as diagnostic expertise. You may even come to a level of a radiologist or a pathologist. In addition, you'll be performing other roles as a teacher, as a team leader, as a researcher, and a lifelong learner. We have to emphasize the importance of the subject. So vision is the simplest and most effective gift that we are giving to mankind, as was spelled out by Mrs. Ashwarya in our inaugural. So we are the first to diagnose systemic diseases and malignancies, and treating children contributes to enhanced productivity of the society. We are treating population from womb to tomb, and mostly otherwise healthy individuals with minimally acutely ill patients or chronic diseases, and our conditions are rapidly treatable. Our surgeries carry, most of them, a wow effect, and with high impact on quality of life of the beneficiaries. We are involved with high-tech gadgetry, lasers, digital high-resolution imaging devices, etc., and cutting-edge research in gene therapy, stem cells, artificial intelligence, bionic eye. Really, sky is the limit. We have ample opportunities for innovations and platforms to showcase those innovations, and an industry interface to take advantage of this. And other advantages that we can be as busy as we want. There's ample remuneration for most of us. There are opportunities for philanthropy for those who would like to do that way. A good lifestyle and a work-life balance with enough me time and family time thrown in. We are the fourth people very happy at work. as the surveys in US tell us. And then, 95% of us stated that we would re-choose ophthalmology as a career. So really, it's a beautiful place to be in. Even in the Indian perspective, we have a high happiness quotient at work, at home, as well as a high career satisfaction. So we have all ample opportunities for future super specialization in the field of choice or the chapter of choice that we start getting interested in. So there's no need for trepidation here. We have to encourage our students to learn surgery. How? By encouraging them with OT etiquette, by washing them, teaching them the wash-up and gown-wearing techniques, how to know their IPD, how to use the microscope. We have to catch hold of the tremors over the tremors, the shaking hands that early residents have. And of course, we have to catch hold of those scared of doing surgery residents who refuse to wash up even for the first time. And we have to emphasize that practice makes perfect. So we have to arrange those dry labs, wet labs, simulators for them, and encourage them to attend the VAST and SSTC platforms to learn surgery. So does institute matters? Of course, we are talking about institutes of excellence and institutes not so of excellence. But honesty about the training opportunities each institute has and has not, has to be totally brought out. The extramural learning can be encouraged from lesser institutes like workshops, PG teaching programs, digital learning, etc. A self-directed learning, interactive learning, and doubt clearing has to be encouraged. We have to encourage their participation in workshops, CME presentations, with opportunities to excel with formative assessment at every step. What not to do? Definitely do not become a rogue faculty. Do not, give insulting criticism in front of patients or other faculty. We do not treat our residents as property, and we have to treat them as human beings, and do not expect no food, no water days from our residents. And doing personal work as a birthright is a definite no-no, and taking little interest in helping them choose a thesis topic or synopsis of thesis writing is not to be done. And getting branded as not to go to person is certainly a thing which we have to avoid. So the interested resident, what we get at the end of it, is a product of our mentoring and facilitation, who is grateful for the meaningful difference we've made in their lives. And the mentor in turn earns their love and respect forever, and it's totally worth it. As for the next part of my talk, when we help postgraduates choose their appropriate thesis topic, so the role of guide is, of course, that of a mentor who mentors his proteges throughout the process. The considerations to choose a topic is the student's area of special interest or a long-term career goal, or the guide's area of expertise, or common conditions encountered in the clinical setting, national priorities, impact on medical practice or policy, and the relevance to the PG program. The directions to give our students who are just going about to choose a thesis topic are to go through previous thesis of the institute, visit the institute library and use search engines, to go through previous issues of the IJO and AIOC proceedings to see what's in, access full text directly or via institute library after taking a printout of the material, and find your area of interest and look up subspecialty journals on that topic. So during the literature search, they should be asked to read at least 10 full texts on each topic of interest and focus on not only the year of publication, but also every aspect of the research methodology, especially the methodology part and the limitations. Now choosing the possible areas of the interest can be done by drawing up a list of thoughts and questions, considering current issues and opinion, leading to newer problems or changes in paradigm that we can think of. The old ones can be put in a newer context or presented as Indian or regional data, or we can identify a knowledge gap when there are not too many good studies on a particular topic, or encourage them to attend a conference or CME or interact with experts in the field of interest if possible. So deciding that type of study is important, whether trials have to be taken up, where we have to get a registry of those trials, or observational studies as are most PG topics, and prospective studies are of course better. So we can decide on the field of research, qualitative or quantitative, and draw up a final matrix incorporating feasible, interesting, novel, ethical, and relevant upon the shortlisted topics, and then elaborate further the listed topics on every aspect to find out another final matrix that will tell us ultimately a topic which is acceptable to both. And then, of course, the cardinal rule is not to bite off more than you can chew. So to do this, you have to match the research question you arrive at with the study design. You have to draw up a proper hypothesis for this. And then you have to calculate a sample size so that you do not land up with a sample you cannot fulfill at the end of your thesis. And then you have to frame your study objectives, both primary objective as well as a secondary objective. And so that ultimately you can sit and actually write down your topic by this acronym of PICOT, Population, Intervention, Comparison, Outcome and Time, which is written for the primary objective in a precise, concise and informative manner regarding the time, place, person, exposure, outcome and study design. Now this is an example of this. This is a topic which really conforms to PICOT, but however is a little bit too complex. This is one of the topics which has won ARC award. And then, of course, to conclude, well begun is half done. So good work helps you publish in a reputed journal and become eligible for the ARC PG Thesis Young Researchers Award of the AIOC. And it's the first step to empower our students to guide someone else for a research later on in their life. So we have heavy responsibility here, and our enthusiasm of both the student and our mentors will lead to the best outcomes for our postgraduates, irrespective of whichever institution they belong to. So thank you for your patient hearing.
Thank you, ma'am, for your wonderful presentation.